for today, I thought I'd take a slightly different approach and take you on a journey with me on how we've come to learn all these things about propionic acidemia. What is the history of propionic acidemia? Who described it first? How did we learn about what it is exactly? And what are the different treatment approaches that were tried over the years, and where are we at today? And then the speakers throughout the day will tell you more about research that is now happening for propionic acidemia, as well as the different treatments that we have available to those who are impacted by propionic acidemia. 14 years ago, I met my first propionic acidemia child. At that time, I learned that it's an extremely rare condition, and I thought probably that's the only person I'll ever meet with propionic acidemia. Little did I know that pretty much every week I'd be admitting a child with propionic acidemia to the hospital during my training at Miami Children's Hospital. And at that time, I learned that propionic acidemia is a very severe condition where children are always in the hospital. They have developmental delay, autism spectrum disorder, and several other complications. I did not know that there was a mild form of propionic acidemia until I came to the clinic in 2013 and met the first person from the community with propionic acidemia and realized, well, there's a lot more to learn. There are different forms of propionic acidemia, and there are many things that we still don't know about this condition. And over the years, I've realized every time we think we've learned more, there's still yet a lot more to uncover. We still don't know why many people go on to develop certain complications. We cannot tell right when we diagnose someone with propionic acidemia who will go on to have those complications and who will not. And we still don't know what are the best treatment approaches to prevent those complications. So as doctors and scientists, we are all still working on learning these things. And today we're going to share all of that with you. In 1961, Dr. Childs and Dr. Nyhan's group described the first case of propionic acidemia. They were at Johns Hopkins at that time. It was not called propionic acidemia. They called it idiopathic hyperglycemia. Idiopathic is a word that doctors use when they don't know the cause of something. That means they had no idea why it's happening. And hyperglycemia means high glycine levels in the blood. Glycine is an amino acid, and it is the only amino acids pretty much that we see elevated in those who have propionic acidemia. So that's the reason for calling it idiopathic hyperglycemia back then. They described the case of a child who had severe complications, and they did not know the exact defect or what this is exactly. I guess I can't see my own slides. Between 1963 and 1967, the name changed slightly to ketotic hyperglycemia, and I'm going to explain what ketotic is. There were many cases reported worldwide. All of them were cases of severe propionic acidemia. And the initial theory was that this is a glycine metabolism disorder because of that high glycine level in the blood. Then eventually, that theory was revised that this is a generalized defect of how the body uses amino acids, which are the components of protein that we get from food. But still, the exact defect was not known of what is causing propionic acidemia. The key features that these doctors identified as the things that define this new condition are, one, ketosis, and that's where the ketotic comes from. Ketones are substances that our body makes when we are starving or we use up our carbs. Then we use our fats to make energy, and we make ketones. If we make too much of them, it can be not good, and we have acidosis. something doctors call ketoacidosis. And these are two things that were seen in the condition at the time, ketosis and acidosis, which means high levels of acid in the blood. And the doctors called it ketotic hyperglycemia because at that time there was another condition that causes hyperglycemia where the ketones were not high. And it's called non-ketotic hyperglycemia. So that's where that name came from. They were trying to differentiate this condition from the non-ketotic hyperglycemia. They also noticed that these children who had this condition had high levels of ammonia. Ammonia is a normal waste product that our body makes, but if you make too much of it, it affects the brain. And they were seeing high levels of ammonia in these children. They also noticed that most of these children did not tolerate too much protein. And when they gave them less protein in the diet, they did so much better. And most of these things resolved, like the ketosis and the acidosis and the high ammonia levels. So this is all the doctors knew at that time. In 1968 and 1969, doctors from Yale University, Dr. Rosenberg's team, started learning more about what could be going wrong in the body in those who have propionic acidemia. And they discovered this by comparing those who have propionic acidemia to those who have a sister condition called methylmalonic acidemia. And they concluded that those who have this specific type of ketotic hyperglycemia have a problem with propionate carboxylation. Very complicated word, but this is what's going to take them to the actual problem in this condition. In 1971, that same group, Dr. Rosenberg's team at Yale, discovered the exact enzyme that was deficient in those with propionic acidemia. And this is when the name changed from ketotic hyperglycemia to propionic acidemia. And what this figure is showing you is the levels of that enzyme called the propionyl-CoA carboxylase enzyme. And from now on, we're going to refer to it as the PCC enzyme. The PCC enzyme is the enzyme that we're concerned about in propionic acidemia. But what this figure is showing you, and I'm not sure I'm going to be able to point, if you see the dot all the way at the bottom, that's the child that has propionic acidemia. And the enzyme activity is pretty much zero. And then if you see the two dots, the dot and the square in the middle, those are mom and dad, the parents of that child. And you see their enzyme levels are higher, but they're still not high enough to be as high as the dot all the way at the top. And that's the person who is not a carrier and not affected with propionic acidemia. So what this figure is showing you is basically those who are carriers for propionic acidemia have about half of the enzyme activity, and those who have propionic acidemia have almost no activity of that PCC enzyme. Between 1971 and 1979, there were more publications describing this enzyme defect, and there was an enzyme test developed where doctors can send that test and know their patient's enzyme activity level. There were also multiple publications talking about what toxic metabolites people are identifying in patients with propionic acidemia. And then there were descriptions of the different presentations, the different symptoms that the doctors were seeing. This is when we started learning more about what does it look like to have propionic acidemia. But still up until this point, we did not know what the gene was that is linked to propionic acidemia. In 1980, and I thought this was very interesting, there was a publication that talked about identifying the genetic cause of propionic acidemia, and it was in an Amish group. And this is a group of multiple children who had propionic acidemia, and this is the closest the doctors finally got to figuring out what is the gene that is linked to propionic acidemia. And I thought it's very interesting that the people who helped them identify that are people from the Amish community. In 1984, there was the first publication that talks about using carnitine in the treatment of propionic acidemia. So up until then, mostly doctors were either not treating or treating by doing low protein diets. And this is the publication that talked about using carnitine in addition to the low protein diet. And the way carnitine works is by helping, because the enzyme is not working, there's buildup of the substance that comes way before the substance called propionyl coenzyme A. And that buildup is not good. And so carnitine binds to that and helps get rid of that by making something called propionyl carnitine, and that's excreted in the urine. So that's one way of getting rid of some of the things that accumulate because of the blockage, or at least that's the thought. It wasn't until 1986 that the doctors finally figured which genes are linked to propionic acidemia, and they identified two genes, PCCA and PCCB, that are linked to the PCC deficiency. It turned out that the PCC enzyme has two components, something called the alpha unit, which is made by the PCCA gene, and something called the beta unit, which is made by the PCCB gene. So if someone has genetic changes in PCCA, two genetic changes in PCCA, or two genetic changes in PCCB, they can have propionic acidemia. If someone has a genetic change in each one of those, they do not have propionic acidemia. They're just a carrier for propionic acidemia. So you have to have two changes of the same gene. In 1993, a group from London in the United Kingdom published about the first report of cardiomyopathy and propionic acidemia. At that time, they had about 19 cases total, and they found that 6 of those 19 children had cardiomyopathy. Those children had other issues, so cardiomyopathy was not the only issue in these kids. 3 of them had passed away because of the cardiomyopathy, and 3 were living. And they found that this cardiomyopathy happened independent of whether they were diagnosed early in life or not, and whether they were on treatment or not. So some were diagnosed early and were on the low protein diet, and still they developed the cardiomyopathy. So this is the first time we're starting to learn about cardiomyopathy and PA, and the fact that it's hard to predict who will get it and why it happens. In 1994, there was the first publication that talks about potentially treating propionic acidemia with gene therapy or RNA therapy. And this group in Canada tried treating cells from patients where it worked. The treatment did fix the PCC enzyme activity. But again, this is the initial step. There was a lot more work to do to take this somewhere. In year 2000, there was the first report of liver transplant for propionic acidemia. And this was for a severe case of propionic acidemia. It was not somebody with mild propionic acidemia. The first person was from Japan. And this is something I've learned as I was doing this literature review, is that there are so many cases of propionic acidemia in Japan. In 2003, propionic acidemia was finally added to the newborn screening test. So anyone born before 2001, 2003, they were not screened for propionic acidemia by the newborn screen or the PKU test. If they were diagnosed early, it's probably because they had a sibling that had propionic acidemia, and that's how they knew to test for it. After 2003, there is a better chance that it gets picked up by newborn screening, yet for the specific variant that we see in the Amish community, it can be, the test can be normal or negative, even though that person has propionic acidemia. And I'll talk a little bit more about that in a little bit. In 2009, a group from Mayo Clinic published the first paper talking about potentially using gene therapy in mice who had propionic acidemia as a treatment. This was very, very early phase of doing this research, what we call the preclinical research. So research that happens in animals, mostly in mice, before we do research in people. And then that same year, a group from New York published about propionic acidemia presenting just with cardiomyopathy, no other health issues, which is something that we tend to see in our community. Patients who don't have any symptoms and all of a sudden they present with cardiomyopathy when they're older or sometimes when they're young as well. And then in 2010, there was a publication talking about cardiomyopathy and propionic acidemia potentially being completely reversible with liver transplant. So that was the first time we learned that the cardiomyopathy can be reversed with the transplant. Although since then, there have been some reports about about the cardiomyopathy reoccurring after transplant, but the doctors still don't know whether that's because of propionic acidemia or because of complications of the transplant. In 2011, Dr. Vendetti's group published again about gene therapy in mice with propionic acidemia. And again, this was an early phase and exploring gene therapy as an option for treatment of propionic acidemia. And Dr. Vendetti is going to talk a little bit more about that later this morning. In 2014, a group in the UK talked about potentially reversing cardiomyopathy using very high doses of coenzyme Q10. And there have been a few more reports since then talking about using coenzyme Q10 as a treatment option in addition to heart medications when someone has cardiomyopathy. In 2016, an interesting publication by Dr. Vendetti and Dr. Manoli's group talked about formulas that we use for propionic acidemia and methylmalonic acidemia. These are the two very similar conditions, and how we should be cautious in how we use medical formulas. We should not be giving too much of them, and whether we should look into developing new formulas for propionic acidemia. So this made us change how we calculate diet for patients. And at one point in my training, we used to give a lot of formula to patients, and we don't do that anymore. We either don't give any or give just a little bit of formula. In 2017, a publication came out talking about using citrates in propionic acidemia. I'm sure some of you heard about that, the use of citrates. In this publication, they basically had a couple of case reports of patients with propionic acidemia where they were getting admitted to the hospital quite a bit, and being on the citrates helped them reduce the number of hospitalizations. So they don't tell us whether the citrates helped with the heart. They just say it helps prevent hospitalizations. So that's the only thing we know about the citrates so far. In 2019, another publication about the Amish community came out stating that, yes, we call this a mild variant of propionic acidemia, but patients still can have life-threatening complications. Early in life, they can still present with seizures, coma, and even die early in life. And later in life, they can present with severe cardiomyopathy and cardiogenic shock, which is basically the heart failing to the point that a person's body cannot function anymore and their organs fail. And to consider this as a serious condition and just not a mild variant. And then that same year, there was a case report of the first time using heart transplant to treat cardiomyopathy in propionic acidemia in a person who just had cardiomyopathy. They did not have other health issues related to the propionic acidemia. And I thought I'd mention this interesting finding when reviewing the literature that in Japan, there's also a mild form of propionic acidemia, and they published quite a bit about it. Through their newborn screening program, they identified a lot of patients like we do who may or may not develop any symptoms, who do not develop the usual complications early in life, like coma or seizures or developmental delays. So I thought that I thought it was interesting that there is a very similar form of propionic acidemia in Japan, where they have a completely different genetic change from the one that we have. In 2003, so last year, there was the first publication talking about both heart and liver transplant to treat propionic acidemia. And I'm not sure if this person was from the Amish community or not. The paper does not mention that, but it was in New York. And then that same year, there is a publication about using mRNA therapy, which is, you can think of it as a type of gene therapy. RNA is the thing between the DNA or the gene and the protein or the enzyme. So it's the step right in between. There was a publication by the team working with Moderna, who are available here today, about using mRNA as a potential therapy, potential treatment for propionic acidemia. So if you have any questions about mRNA therapy to treat propionic acidemia, feel free to visit their booth today and ask them those questions. Most of the publications for propionic acidemia were actually in the last 2 decades. So I looked at, I guess did not read every single publication, but I reviewed the entire list of 800 publications since 1961. And 200 of those publications were in the first 40 years. 600 were in the last 20 years. So a lot of publications in the last 20 years. And most of them were focusing on what we call the pathophysiology. That means the doctors are really trying to understand, what does propionic acidemia do to the body? What is it that's harming the heart? What is it that's harming the brain? And they're digging into that pathway, the metabolism that occurs in propionic acidemia, and how does it affect the body? Also, there were a lot of publications about how to manage propionic acidemia during illness and also during well days. And doctors call those guidelines. That's what we use to help with your treatment. We don't come up with what we like. We have these published guidelines and we follow them. That way we provide you with the best care possible. There were a couple of natural history studies where people tried to learn about the progression of propionic acidemia over time and learn about, are there a lot of deaths? What are the causes of death? Are there certain complications that happen? At what age can they happen? And natural history studies are very important when we're trying to come up with treatment options for a condition. They're kind of the foundation to finding a cure or a treatment. There were so many case reports of unusual presentations, different case reports from countries where they did not think they have propionic acidemia, then they found that they do have it, and description of what we call the spectrum of the symptoms that we can see. And then people were sharing their experience with liver transplant. A lot of places were using liver transplant for treatment, and they were sharing their experience, what complications can happen. Are there recurrences of certain things? How do we manage patients after a liver transplant? So we learned quite a bit, and despite the 800 publications, there's still a lot to learn and a lot to publish. Publications are the way we doctors share knowledge with one another, and that's how we learn, and that's how also we teach you things and share things with you. If we don't have publications, then we're on our own with you, and sometimes we don't know what to do. So they're a very important part of our learning and your learning. So now I'm going to end with what we know now about propionic acidemia. So propionic acidemia, the name comes from the buildup of propionic acid in the blood. People always wonder what does the name mean? And most people call it PA in the community. A little bit more about the metabolic pathway in propionic acidemia. And I decided to share some slides that our summer intern made for us where he simplified these pathways. These are very complicated metabolic pathways, but he simplified them for us here. And I guess I messed up the order of things here. It's not supposed to look like that. But we have 4 amino acids, isoleucine, methionine, threonine, and valine, that come from food. You have food, protein gets broken down into amino acids. These 4 amino acids are the ones involved in this metabolic pathway. Then we also have cholesterol and odd chain fatty acids. So part of fat metabolism. This is going way faster than I thought. All of these get broken down and reach something called propionyl-CoA. Then propionyl-CoA gets metabolized to methyl-malonyl-CoA, which gets metabolized to succinyl-CoA. And succinyl-CoA feeds an important energy cycle in our body called the Krebs cycle. And like our intern summarized, lots of confusing names. That's why we're not sharing them. But it's an important pathway in our body that's responsible for making energy. So the end goal of this pathway is to produce energy for the body. Now we zoom in a little bit to focus on the part that's relevant to propionic acidemia. So we have the propionyl-CoA supposed to make methyl-malonyl-CoA using the PCC enzyme. The PCC enzyme has different components like I mentioned earlier. It has the alpha unit made by the PCCA gene that's in yellow here in the picture. It has the beta subunit made by the PCCB gene that's in blue. And then there is a little component called the cofactor or the enzyme helper, and that's biotin. I'm sure some of you have taken biotin at some point. That's what biotin is. It's an enzyme helper that can help it with its function, which in this case is making methyl-malonyl-CoA from propionyl-CoA. Now, in those who have propionic acidemia, we have genetic changes in one of those genes, and that means the enzyme does not work. And when the enzyme does not work or does not work well, you have buildup of that propionyl-CoA, and you're not making methyl-malonyl-CoA. So one thing goes really up and one thing goes down, and that means you're not making enough energy, because remember the goal of this pathway is to make energy. Also, something else happens whenever there's buildup in our body tries to get rid of it. And it gets rid of it by making other things that potentially are harmful to the body. So in this case, the propionyl-CoA becomes different things called propionyl carnitine, methyl citrate. You might have heard about methyl citrate if the doctors were sharing some test results with you. 3-hydroxypropionic acid, glycine, the amino acid that I mentioned earlier. So there are different metabolites that build up in the body, and we're trying to learn which ones are the toxic ones and what do they do exactly. And we still don't know that for sure. These are things that we're still working on and trying to learn. Propionyl carnitine is referred to as C3. And that's the number that can be high on newborn screening. So this is one way you can get a diagnosis of propionic acidemia through the newborn screening test. But for it to screen positive, that C3 level has to be high enough. Each state has a cutoff number that they set. And if you don't make that cutoff, you will not be picked up by the newborn screening test. And we know that in the Amish community, the C3 level sometimes is not high enough right at birth, that several people are missed by the newborn screening test. In our own patients here at the clinic, 50% of those who we see were not picked up by newborn screening. They were either diagnosed after their sibling got diagnosed by newborn screening, or because they showed up in the hospital and they were really sick, or they got cardiomyopathy when they were older. So that's a large number of people who get missed by the newborn screening test. Another way of getting diagnosed is what I just mentioned. So if you're missed by newborn screening, you may get diagnosed if you have symptoms. And usually when doctors see certain symptoms along with certain abnormal lab results like that ketosis and acidosis and high ammonia, they think of conditions like propionic acidemia and they order several tests. They order blood and urine tests. And if they order amino acids, for example, they will get the high glycine level. If they order something called acylcarnitine, they'll get high C3 level. And if they order a urine test, they might get multiple of those toxic metabolites we just talked about. Then they combine all that information together and they say, oh, this looks like propionic acidemia based on all these things. They cannot tell just from one of these. They need all of them to say this is propionic acidemia. And of course, the best way to confirm the diagnosis is always to do the genetic testing. When we say we're going to do genetic testing, we're basically taking a sample of blood or saliva, and we look at the DNA. Our DNA is made up of these 4 letters, C, G, A, and T. And basically, the genetic testing is reading through the sequence of these letters. And if we find any misspellings that are significant, that's what we tell you when we give you the results of the genetic testing. Specifically in the Amish community, the misspelling is in the PCCB gene. And instead of a letter A, there's a letter G. That simple change in the letter causes a condition as serious as propionic acidemia. And that's the case for all the genetic conditions that we see, not just propionic acidemia. Just one misspelling makes a person at risk for several health problems. So how is propionic acidemia inherited? It is inherited in what we call autosomal recessive inheritance. Both parents have to be carriers for a child to be at risk of having propionic acidemia. In this image, the blue color represents a gene with a change in it, and the yellow color represents a healthy gene with no change in it. So think about that PCCB gene. You have mom and dad. They each have one healthy copy and one copy with that change in it. Every time there's a pregnancy, there's a chance that parents pass down the copy with the change. And that's when they have a child with propionic acidemia. In this picture, it's the child who's all blue. Every time they pass down the healthy copy, they have a child who is not even a carrier like them. That's the child who's all yellow in here. And every time they pass down a mix of a healthy copy and a copy with a change, they have a child who's a carrier like them. It ends up being 1 out of 4 or 25% chance with each pregnancy that a child could have propionic acidemia or could be not even a carrier. And 2 out of 4 chances or 50% chance that that child could be a carrier like the parents. We do not choose what we pass down to our children. These things are very similar to eye color. We do not choose what eye color we pass down to our children. So this is something that we cannot change. There is nothing you can take before the pregnancy or during the pregnancy that can change how these things are passed down. At the clinic here, we are a newborn screening follow-up center. That means if there is a positive newborn screen, they call us and they tell us about it, and we're in charge of doing the follow-up and confirming whether the person has that condition or not. And the 3 conditions that we diagnose quite frequently in the community are PKU, PA, and another condition called VLCAD, which has to do with fat metabolism, not protein metabolism. Newborn screening is great at giving us an early diagnosis. The issue is not everyone is picked up by newborn screening. So there are people out there who have propionic acidemia and they don't know because they were missed by newborn screening. And that's why what we're advocating for is doing carrier screening, where any adults who are from the plain community get tested for what they're carriers for. So if you know ahead of time what you're a carrier for and what your spouse is a carrier for, we can do cord blood testing on the baby, and we can confirm whether they have propionic acidemia or not. We don't have to wait for the newborn screening test. We still need to do the newborn screening test, but we don't have to wait for it. And also, if the child gets missed, we pick them up by the cord blood testing. So this is what we advocate for and what we tell all our families to do. That way we don't miss anyone. What kind of symptoms can we see in propionic acidemia? In severe propionic acidemia, and also in mild propionic acidemia, if the child gets sick, these are some of the symptoms that we can see. We can see that the child is not feeding well, they're lethargic, they have low muscle tone, and they may have seizures, and they may also progress to be in a coma. And we've seen a couple of kids in our community who were in a coma early in life because they were very sick at that time. And the severe type of propionic acidemia, kids can have all of these symptoms even though they're not sick. Just by eating too much protein, they get very sick. But the symptoms that we tend to see the most in our community are the heart symptoms, or what we call the cardiac complications. And the two main ones that we see are a long QT interval. And I guess I'm not a cardiologist. I'll leave it to the cardiologist to tell us more about this. But there are two tests that we do usually. We do an EKG, which is a tracing of the heart electrical activity. And we do an echo, which is an ultrasound that shows us the inside of the heart and how it's functioning. The EKG shows the electrical activity of the heart, what you see as a nice tracing over there. And we doctors like to have codes for everything. So each peak in there has its own letter. And we're referring to the QT, so that the time it takes for the heart between the letter Q and the letter T. In people with propionic acidemia, that time is longer than the usual. So that's what we mean by prolonged QT. Or if you go to the doctor, they might say, oh, you have long QT syndrome. They don't know you have propionic acidemia. They think you have this other heart condition where the QT is long. And then if we do an echo, we can see that the heart is dilated. It's larger than what it is, and also the walls are thinner, like the picture is showing. The muscle around the heart is thinner. And when the muscle is thin, it can't pump as well. It can't work as it should. And we will hear later more about these cardiac complications. Like I mentioned earlier, we still don't know who will go on to have these. We can't diagnose someone with propionic acidemia and say, oh, you are going to have the heart complications, but you will not. And this is why we have to see you regularly. We have to do the EKG and echo regularly so we don't miss anyone who will go on to have those things. Maybe one day we will have more tools to know who will go on to have these complications. Then we wouldn't have to do the frequent monitoring anymore. But at this point, we don't. And that's why we do things the way we do them now. How does the treatment look like at this point for propionic acidemia? There are three main things that we do. We change the diet. We tell you to eat a low protein diet, and we may or may not ask you to use a special medical formula, which is what is shown all the way on the left here. We might ask you to take some vitamins and supplements like carnitine, and then we tell you if your child is sick, or if you are sick, please let us know because we might need to go to the hospital and get IV fluids. So those are the three main things that we do for propionic acidemia. But that also means we need to see you frequently. You need to see a dietitian frequently and talk about the diet, how much protein are you eating. And also there are blood and urine tests we have to do to make sure things are going well. Are we restricting too much protein? We don't want to do that. So we're always checking the amino acid levels to make sure you're eating enough, but not too much and not too little. We might check some of those toxic metabolites to make sure nothing is building up too much. We might check certain things like acid levels or ammonia levels if your child is sick in the hospital. So there are a lot of tests that we do all the time to monitor things and make sure we are stable. Specifically here at the Community Health Clinic, we offer several services for propionic acidemia patients. We have a newborn screening coordinator. Her full-time job is to make sure anybody that screens positive on the newborn screen, she contacts them. She makes sure they get all the testing that they need, that they understand what the condition is. We have a nurse that might go to the home. Sometimes I go to the home myself if we need to do certain things at home. We have what we call a metabolic clinic, so that involves a metabolic geneticist and a metabolic dietitian. We have heart specialists, cardiologists who come to the clinic and see patients. Like today, we have Dr. Chowdhury here. She is seeing people who have PA. We have a neurologist who sees those who have developmental delay or seizures. We have a case manager that coordinates everyone's care if you need an appointment, if people need special testing, eye exam, hearing exam, anything like that. She's the one that coordinates that for them. We offer free or low-cost testing. We collect the labs here at the clinic, but we do not have our own lab, so we don't run anything at the clinic. We ship everything out. We offer carrier screening clinics for any adults who want to know whether they're carriers for propionic acidemia or not. We have a 24/7 call service, so families can call at any time and reach one of us. And we do a lot of these family days and education events. We have also been a site for research studies that focus on propionic acidemia or similar conditions. All in all, our clinic saves people $5,000 to $10,000 every year while taking care of their propionic acidemia and receiving services that typically they would only receive at a large medical center. So despite all these things that we've learned about propionic acidemia, like I mentioned throughout this presentation, there are several challenges. One, the fact that propionic acidemia in the community is missed by newborn screening. That means we don't know the exact number of people who have propionic acidemia. Unless they show up at a hospital really sick, we will never know how many out there have it. Most of these publications that I talk about the classic or the severe type of propionic acidemia. They don't talk about the Ammous variant of propionic acidemia. So the more work we do with our community, the more we publish is actually really good for us because that's how other people get involved with us and other people help us find better treatments. There isn't a well-described natural history study of this condition in the community, and we don't have specific treatment guidelines for the propionic acidemia that we see in the Amish community. There are guidelines for propionic acidemia in general, but we know that this variant is very different, and we don't have specific guidelines. So what we do is we take the guidelines that we have for the severe propionic acidemia, and we modify them a little bit to fit our type, but we don't have something that is published out there that we can all follow. That's all I have for you this morning. I think I used all the time. I'm supposed to leave time for questions, but if you have any burning questions, we definitely have time because it's break time. Thank you for listening.